So we now move to the 2015 Jacques Miller Medal. And the Jacques Miller Medal is also being awarded for the first time this year. It recognizes research of the highest standing in the field of experimental biology research and is made in honor of the contributions made to science by Professor Jacques Francis Albert Pierre Miller, a Fellow of the Academy. The inaugural recipient of the 2015 Jacques Miller Medal is Professor Michael Cowley, and I invite Michael to come to the stage.
Professor Cowley has discovered how the body informs the brain about the amount of body fat we have and how much sugar there is in our blood. Through his understanding of these metabolic pathways in the brain, he's devised new drugs to treat obesity. He's also recently discovered why obesity causes high blood pressure. He's received several awards for his research and now leads a global effort to find new drugs to treat diabetes. Michael, congratulations. I invite you to present your talk.
Thanks very much, Marilyn. I owe a debt to the Academy for bestowing this award on me. Thank you very much. I'm honoured. I also think it's important we recognise the generosity of Sir Mark and Lady Feldman in providing these awards. And thank you very much. And I'm humbled to be receiving an award named after such an eminent scientist as Professor Miller, so thank you all. I also owe a debt of thanks to my many mentors, and in particular I should acknowledge Professor Short here, who was my honours supervisor many years ago. He's a member of the Academy and very active yesterday, I noticed. Finally, my parents and my mother is here, and so thanks Mum and Dad. I'm going to talk to you today about work we've been doing in the lab over the last 15 or so years about understanding how the brain interprets signals from the body. It's almost 20 years to the day that leptin was cloned, and leptin was at the time thought to be the way the body informs the brain about fat. And it was decided that the brain was the fat controller. If there's anything I can teach you in this short session, it's that body weight is encoded by the brain. It's not a simple consequence of what you eat. We are more than what we eat. We're a consequence of our genetics and our environment. And so the brain has a set point for your body weight. It helps you maintain a relatively stable body weight across your lifetime. And leptin was thought to be the major signal that drove this controlled body weight. And it was felt 20 years ago when it was cloned that all we'd need to do is to make more leptin and give it to people and they'd lose weight. And so we would correct what we recognised even 20 years ago as a growing problem. The extent of the problem is significant though. Something like 70% of Australians are obese or overweight. And that comes with it a variety of risks of metabolic diseases that are currently providing significant economic costs and personal costs. But those economic costs are rising as obesity rates rise because many of the diseases that are caused by obesity lag by about 20 years. And so we've seen essentially no change in the rate of heart disease, primarily because of the reduction in smoking, primarily because obesity-induced heart disease risks have increased in parallel as smoking-related risks have decreased. We're yet to really reap the consequences of obesity on diabetes risk. We have a national incidence of about 8%, but it's going to rise. And it's going to rise dramatically in our near neighbourhood as well, as affluence spreads through the region. This is a slide put together by one of my graduate students, the student who's done most of the work in this presentation. I like it because no one can understand it primarily. But what it points out is in these two purple boxes we have Australian men and Australian women and their incidences of obesity. And you can't find any region in the world where that increasing incidence is not occurring. So this is not just a disease of the developed world. It's not just a disease of places that can afford adequate healthcare systems to deal with these disease costs. It's a condition that's striking everywhere in the world. And in many cases it exists side by side with abject poverty and hunger. It's not just people. This is a large creature called Meow who weighed in at, I think, 25 pounds, I'm sorry. I switched between the US and Australia. Meow died not long after this photograph was taken. His owners insisted that Meow only ate a normal amount of food. I think we'd often find that hard to believe. Now, 20 years ago, Jeff Friedman, a friend of mine from the Rockefeller, cloned leptin. And as I said, this is the major signal by which the brain is informed about how much fat you have in your body. It's secreted by fat cells, and You can see in the little mice down here, the lack of leptin leads to a very large animal, and when the hormone is replaced, you get a normalisation of the phenotype of the animals. The body weights drop away, you get improvements in insulin sensitivity, and interestingly, we see changes in animals' temperature, metabolic rate and activity as well. So in the face of a lack of fat, in a perceived lack of fat, the brain is regulating not just appetite, but also behaviour in terms of energy expenditure, and processes around sympathetic activation of fat that lead to changes in changes in body temperature. I said it was expected to be the fix for obesity, and certainly for people like this young boy here, it was. This is a fellow of Pakistani descent from what we call a highly consanguineous family. His siblings and he lack leptin. They're treated by a guy called Steve O'Reilly in Cambridge. And you can see here that at 3 years old, this young boy weighs 42 kilograms. He's very big. At the beginning of leptin therapy, at that point, 3 years later, you can see he weighs 32 kilograms and essentially looks normal. His sisters went through menarche once they began leptin therapy, and so for these handful of people, some 30 or so in the world, leptin really is the magic bullet fix. Late last year, leptin was approved for the treatment of lipodystrophy as well, a condition of chronic lack of body fat that's characterised by a variety of metabolic sequelae, including severe insulin resistance. So for some people, leptin really has been the magic bullet. Leptin works, and this is an illustration, I guess, of the fact that there are multiple processes the brain engages in response to leptin. But this is a study done by Rudy Labelle in New York, where he brought patients in, measured their food intake, and then increased their food intake to cause a weight gain. What they measure is, in consequence of that food intake increase, there's a 10% increase in energy expenditure measured by indirect calorimetry. So the patient's brain is actively campaigning to prevent weight gain. And similarly, when he reduces their food intake, the patient's brain campaigns to reduce weight loss by decreasing energy expenditure. And we believe this is the reason for which diets do not work, that the brain senses how much fat you have, and if you start to deviate from that set point in fat, this point of epistasis, the brain will change the amount of energy you're burning to return you back to that pre-changed body weight. And one of the most exciting things about this study that Rudy did was that this compensatory decrease in energy expenditure could be prevented by returning leptin back to the levels it was before they began the diet. So leptin by itself doesn't work to cause weight loss. Patients who are obese are resistant to leptin. And Jeff Friedman's trials showed that they could give leptin at levels of almost like a food value, the amount so much was being infused, and not cause weight loss. But in this situation, you can prevent a compensatory decrease in weight loss. Now, over the last many years, my lab's worked to map how the brain detects this leptin signal and how it uses that information to make those changes to energy expenditure and to food intake and body weight. And what we've developed is a circuit map through the brain of the neurons that detect leptin and then engage second-order neurons further into the brain to regulate either appetite or energy expenditure. And we've used this information to develop a series of medicines that are now in use to cause weight loss in patients. And this is the data from one of the clinical trials. This is a phase 3 trial with one of the inventions from the lab. And we can see here about a 6% placebo-adjusted weight loss associated with use of these medicines that reactivate the circuits in the brain that leptin normally works through. Now, 6% weight loss is not going to turn a very obese person into a supermodel, but it is more than enough to cause a metabolic benefit that's useful. What we've also discovered, though, is that this brain-driven activation of the sympathetic nervous system is not as specific as we'd like. So to give you sort of a broad picture, we have the hormone signal leptin coming from animals' fat. It travels through the circulation to the brain, and it acts on a region of the brain called the dorsomedial hypothalamus, a region a fair way into the brain that has been known to regulate body temperature, but it really wasn't known how it regulated body temperature. We were able to show, using electrophysiological recordings, that leptin activated these neurons, causing them to fire more frequently, and that signal was propagated down the sympathetic nervous system, where it caused an increase in the activity of the sympathetic nervous system to brown adipose tissue, the fat that creates heat. And it burns a lot of energy by doing that. In addition, and unfortunately, in what we call a mean trick of nature, the sympathetic nervous system outflow is not nearly specific enough, and so we get activation of sympathetic outflow to the heart and also activation of sympathetic outflow to the kidney. And so the very therapies we might use to try and cause weight loss also increase blood pressure and heart rate. And so this has highlighted that we need to pay attention to these potential side effects, because this axis of fat to BAT isn't specific enough, and we also get an attack, or you get increased activity in the heart and kidney. So it's reminds me to think, to me, this means that we need to describe the role of obesity, not just in terms of as a risk factor for hypertension, but because obesity is now, we can say, directly increasing blood pressure. And I think that's important because as humans, we're terribly poor at calculating the effect of risk. So that's it. Thank you.
Thank you very much. Questions for Michael?
Marilyn, here. Would you like to make a comment about the so-called 5+2 diet, where separate days of the week you have only, like, say, 500 calories if you're a female, and the rest of the time you can eat what you like?
I guess 2 points. We need to be careful because I know Robin is a big fan of this diet, so I can't say too much against it. Look, I think diets are, just like we all become obese for our own particular reasons, with 70% of the population overweight or obese, there's not one problem that's causing it. So too, individual solutions are important, and I think, you know, if you look at the historic foods that people eat in different parts of the world, there's no right diet, there's no particularly wrong diet. I mean, you look at what the Inuit eat, a diet of meat and blubber, you would expect that you'd get very sick on that, and maybe you would in this part of the world. So there's no right diet, there's no wrong diet. I think if it works for you, that's wonderful. Does it mean it's going to work for your neighbour? I don't know, and I think we don't understand enough about the different biologies going on there yet to answer that question. So try it and see.
Thank you. I just wonder how much the 30% of people who aren't overweight are interrogated for what's going on there.
It's a really good point, yeah. And they're not to any great extent. There's a large-scale genetics effort underway in the UK looking at what are some of the genetic drivers of extreme weights. But the genetics of body weight, like the genetics of many factors, and Mike Waters yesterday talked about the genetics of height, aren't bringing out the sort of smoking gun genes. The things that we know about in obesity genetics account for something between 5 and 10% of the incidence we see. So there's much more out there that's yet uncovered. Similarly, the genes for severe leanness are not really well documented. Certainly, the genes that disrupt the formation of fat, the lipodystrophy genes, lead to severe leanness, a complete lack of body fat. But that's very pathological. We know those genes, but they're not the solution to any of the problems we see. In other situations, some of the genes that are involved in transducing that leptin signal in the brain have been highlighted as being important for regulation of body weight at both extremes, and we know them as well. But again, they're not really therapeutically amenable. You don't want to knock out a neurotransmitter in the brain, for example.
Thank you very much, Professor Cowley.
Thank you.